Hello, everybody. It's my great pleasure to introduce you to this webinar on hypertrophic cardiomyopathy, pathways to better care in different settings, organized by the World Heart Federation, a global organization based in Geneva, Switzerland. I am Fausto Pinto, the immediate past president of the World Federation. I'm a professor of cardiology at the Lisbon University Medical School, and it's my great pleasure and privilege to host this webinar today. We have a fantastic faculty that will be developing some of the themes regarding the topic, and we'll have some time at the end for some discussion and some questions from you. Well, cardiomyopathy, the condition we'll be dealing today, it's actually a very important condition. It affects approximately 15 to 20 million people at a global scale. It can be a very devastating condition, predisposing people to heart failure, arrhythmias, and even premature sudden cardiac death. In the majority of cases, it is a hereditary condition through known genetic variants that we already know, although it can be caused by other factors, including certain congenital or even diseases. While hypertrophic cardiomyopathy, it's a condition that clearly poses an important burden for patients, for their families, and wider communities. Significant challenges still persist. Importantly, these challenges they vary significantly according to the location, to the setting, the context where people live. Limited awareness and education, particularly among non-specialized physicians, and under availability of family-based services such as genetic counseling continue to impede optimal care in all the different settings. In lower resource settings, additional challenges such as the lack of access to imaging technology and lack of representation of populations, for instance, from low and middle income countries in clinical trials, it's still a very important challenge. We have today our distinguished presenters that will dive deeper into all these different challenges and will share with you their vision for bringing improved care to people with hypertrophic cardiomyopathy at the global level. And it gives me my great pleasure to introduce our first speaker, Professor Anjali Owens. She's an associate professor of medicine at the University of Pennsylvania in the US. She's the founding director of the Pan Familial Cardiomyopathy Program, director of the Hypertrophic Cardiomyopathy Clinic, and she was appointed as the medical director of the Penn Center for Inherited Cardiovascular Disease in 2015. She will present, the title of her presentation is Improving Health Professional Awareness and Care of Hypertrophic Cardiomyopathy, where we are and what we still need to do. So Anjali, the floor is yours, or the screen is yours.
Thank you so much, Professor Pinto, for that introduction and for the kind invitation to speak today. Thank you to the organizers from the World Heart Federation. So as Professor Pinto said, we'll dive right in. Here are my disclosures. And let's talk a little bit about the epidemiology of hypertrophic cardiomyopathy, which of course is classified technically as a rare disease. But as Dr. Pinto said, Professor Pinto, the prevalence is at least 1 in 500 individuals, and this condition affects men and women, people of all ages and all ethnicities worldwide. So if you look at the estimated population of affected individuals, we are talking 15 to 20 million people. And a take-home point here today is that the vast majority of these individuals are currently undiagnosed. They are not aware that they have this condition. And we'll talk a little bit about what the gaps are in making a diagnosis and then subsequently managing patients with hypertrophic cardiomyopathy. So number one, we know that cardiac imaging, specifically being able to accurately measure wall thickness, is critical in making a diagnosis, but imaging is currently underutilized. Patients frequently report misdiagnosis, or what I call partial diagnosis. They're diagnosed, for example, with atrial fibrillation, but nobody has looked to see that it's the underlying cardiomyopathy that's causing atrial fibrillation. And finally, we know that even after patients receive a diagnosis, access to expert centers and specialty care can be limited. So let's talk first about the challenges in diagnosing HCM. We frequently see that patients are given a diagnosis of left ventricular hypertrophy. The walls of the heart are thick. But we know that there are a number of causes of left ventricular hypertrophy, including very common ones such as hypertensive heart disease or aortic stenosis. So it's no longer enough to say this patient has left ventricular hypertrophy. We need to really delve down into the specific etiology of hypertrophy. And that can include, of course, hypertrophic cardiomyopathy. And in that group of patients, we know that we are able to isolate a sarcomeric change in the sarcomeric proteins, a pathogenic variant, we term that. And I have listed on the left the most frequently affected genes for sarcomeric hypertrophic cardiomyopathy, but we know that there are other conditions that can look like hypertrophic cardiomyopathy, and we call those phenocopies or genocopies. An important one that I've highlighted is amyloid, which we know now has very specific treatments, and some of these other conditions do as well. So it's important to make the correct underlying diagnosis so that we can get patients to the right targeted treatment. Another challenge we see in making a diagnosis is that patients with hypertrophic cardiomyopathy can have a range of symptoms. Many patients can be completely asymptomatic and they're only picked up by screening or family history. Other patients can have nonspecific symptoms that are identified incidentally, and these symptoms can overlap with other very common cardiopulmonary conditions. So, shortness of breath, dyspnea on exertion is a very common complaint in patients with hypertrophic cardiomyopathy, which can occur for a number of reasons. We also see chest pain that can be typical or atypical, lightheadedness, dizziness, palpitations, and fatigue. And because this is a chronic condition that's often lifelong, patients can adapt their lifestyle slowly over time to accommodate these limitations as their symptoms gradually progress. So when you first meet them in the office, they may initially say, "I'm fine, I don't feel limited." But if you really track back to what their history has been over the years, over the decades, and you speak with their family members, the limitations can become apparent. The delays in diagnosis we see are quite common. This was put together in a publication that we really recently did of about 4,000 patients who had obstructive HCM, and almost 60% experienced a delay in getting a definitive diagnosis, with a mean of 4 misdiagnoses or partial diagnoses before the definitive diagnosis was reached. And approximately 80% of these patients had visited a cardiologist, and that's important. So as healthcare professionals, cardiologists in specific, we need to keep hypertrophic cardiomyopathy on the differential diagnosis in order to be able to make the correct diagnosis. We know that the phenotypic expression and the outcomes can vary in HCM by sex, and men and women can present differently. We often see that women present later with more severe symptoms and more heart failure, and only 1 in 3 patients in the referral centers cohorts are women. So we know that we are probably missing this disease until it's at an advanced stage. This may get to a more personalized diagnosis in terms of wall thickness. We currently use a one-size-fits-all approach, and we're getting an increasing data that probably is not the right approach for every individual, and we'll get hopefully more sophisticated with our threshold of diagnosis in the years to come. We also have conflicting data with regard to the diagnosis of our Black and white patients. Suffice it to say that these patients are underrepresented in studies and in research studies, and we really need to increase access to care for all of our patients so that we can understand if there are important differences and how to treat them. And finally, challenges in the treatment of HCM. Hypertrophic cardiomyopathy, I would submit to you, has unmet therapeutic needs. Our current medical therapies, for the most part, were not specifically developed to treat the underlying pathophysiology. When patients have severe obstruction, they're recommended to have septal reduction therapy if they fail medical therapy, but optimal results really require specialized care that's not widely available in many areas of this country or the world. So there is an unmet need for pharmacologic therapies for symptomatic HCM. Here in the US, a study was recently done that showed that definitively better outcomes if you get your septal reduction therapy at a high volume center. However, 70% of procedures were performed in low volume centers. So we are not doing the best for our patients to give them the best outcomes if we don't get them in the right hands. Here's the access issue that we have in the United States. Lisa Sahlberg will talk to us later today. Here is the map of the Hypertrophic Cardiomyopathy Centers of Excellence, and Lisa has tirelessly worked to increase the number of centers, but still there are areas of this country where we have a difficulty accessing specialty care. We have barriers to family-based care. I already mentioned geography, but also a lack of genetic counselors who are really critical in communicating results of genetic testing. We still encounter issues with privacy, insurance discrimination, access, and cost of genetic testing and clinical screening. The burden of disease can be high. This is a qualitative study that was done recently and really shows both the positive but also the negative effects that our patients can have upon receiving a diagnosis and living with hypertrophic cardiomyopathy. And I think we need to take this into account and really meet our patients where they are so that we can help them to live the best quality life possible with this condition. So I would submit to you here are some future challenges and recommendations. In terms of clinical trial participation, we need to diversify our participants, think about endpoints that may be different than standard heart failure endpoints. Access to novel therapies, really we need to delve into implementation, logistics, and cost. We need increased access to genetic counseling, better variant interpretation in terms of the genetic testing, specifically with regard to underrepresented populations, go beyond a one-size-fits-all approach for diagnosis, and think about special populations, including children that are transitioning to adult care. So I will stop here. Here is a picture of our team here at the University of Pennsylvania, and thanks again for the opportunity to speak today.
Thank you so much, Anjali. I think that brings a lot of food for thought, and I'm sure you're going to have some questions towards the end, and I have time to explore some of the concepts that you just mentioned to us. And it's now my big pleasure to introduce the next speaker, Dr. Sarah Kraus. She's a senior clinical researcher at the University of Cape Town in South Africa. Sarah is a physician researcher based in South Africa with a focus on cardiomyopathies and heart failure. And among other projects, Sarah is a key researcher in a leading project, the IMHOTEP study, which is a Pan-African prospective cohort looking into the genetics, the pathogenesis, and burden of cardiomyopathy in the region. Very important. Her presentation title will be Stepping Up Research and Care for Hypertrophic Cardiomyopathy in Lower Resource Settings. Certainly a very important topic for this discussion. So Sarah, please go ahead.
Thank you very much for the introduction and invitation. So the question here, I have no disclosures. So the question is, where do we begin? And when you come from a low middle income setting, there's always this balance between the burden of disease and resources. And it's actually finding that critical balance that's really important and quite challenging. So where do we start? Well, the question is, firstly, we don't really know what the HCM burden is in a lot of the countries of the world, particularly lower resource areas. So we don't really know what we're dealing with. But we also know from international information and all the work that's been done in higher income countries that the resources required to look after these patients are particularly high. There are imaging teams that are needed. There's also subspecialist care that's required. And the interventions are quite specialized and quite difficult to access even in the first world setting. And so where do we start with this? The idea really is to first understand the quantity of burden of disease within low middle income countries, and then to try and reduce the costs of providing care so that we can find an equipoise between these two things. When you practice in low middle income settings, which I've done throughout my entire career, you realize that you're always stuck in this moral bind of realizing that you can't function in isolation, that your resources are allocated according to need, but will never reach the need that is required within your specialty. But you can't work in isolation away from what everything else and every other specialty demands. So how do we quantify the burden of disease? Well, the first thing is that there is a large gap between evidence-based practice and the research platform, particularly in low middle income settings. And so there's this great need for longitudinal data that comes from those settings in order to understand the incidence and prevalence of these diseases, the genetic underpinning, the relationships between the environmental factors unique to those regions and disease, cost effectivity, and outcomes. And so one of the ways in which we want to consider filling the gap is to first provide longitudinal data, because longitudinal data then has the potential to direct research and clinical practice that is relevant for that region. So what I want to do is spend a little bit of time about and explain to you a little bit about our experience over the last decade and what we've done to try and fill the gap. We created the EMOTIP study, which is the African Cardiomyopathy and Myocarditis Registry Program in 2014. And this is essentially a clinical registry that has multiple facets to it and a biorepository. We also have the capacity to do individual and family-based sub-studies in both molecular genetics and the clinical services. And it's the idea of bringing people from different regions of Africa together so that we can share in local expertise. So the collaborative clinical registry and biorepository was really established to systematically collect data on both adults and pediatric patients with heart muscle disease from multiple regions across Africa, because we wanted to understand more about the epidemiology, the clinical manifestations, genetics, environmental contributors, and outcomes. But at the onset of creating the study, we thought about the three facets that we really needed to fill. The one was research, so strengthening African-based research capacity. And secondly, clinical care, so augmenting clinical practice in the resources restricted settings, and how do we translate that in to improving the care and outcomes for our patients. And then thirdly, about promoting scholarship and training, so education, and how we increase awareness within the clinical service. So EMOTIP has just completed its pilot phase, which was a multi-centered phase involving 7 sites in South Africa and Mozambique. A number of institutions in the region have come together, and it's a collaboration with Oxford University as well. So when we look at the EMOTIP study and the recruitment of more than 800 patients, we can see that cardiomyopathies occur throughout the lifespan, and that the types of cardiomyopathies that we see in our setting is predominantly dilated cardiomyopathy. And HCM forms about 10% of the adult cohort. Still significant. But what has this research taught us? Well, the first thing is that recruitment of HCM cases was extremely low, and we were quite surprised by that initially. One of the things is that we kind of thought of was that our burden of disease is actually higher in DCM. And that means that we're actually focused towards DCM. And this is illustrated in the way in which patients were recruited. We also note that patients predominantly get to hospital in our setting because they present with heart failure. And if only approximately 20% of HOCM patients are presenting with heart failure, those are the only patients that are accessing referral for further investigation. We've also noted that there's limited access to imaging at primary and secondary care levels that may be limiting referral to cardiac centers where we've been recruiting patients. And the last thing was that we actually noted that all our HCM patients were recruited from the primary center. And that was partly because the other centers were not centers that really were tertiary, quaternary centers that had the expertise with a number of cardiologists or healthcare professionals that were well-versed in HCM. And there was a lot of recruitment inertia from those non-tertiary centers because patients weren't presenting to those centers, but also because physicians didn't feel confident in making those diagnoses. There were some notable similarities of the European and North American cohorts. The age of onset in HCM specifically is very similar, gender distribution and clinical manifestations of the disease. And the genetic underpinning is also similar, except for the fact that we see a lot less of familial disease in our setting, and the genetics reflects that. So our yield overall is lower, but the makeup of the genetic causes of HCM are very similar. So how can we take this research and the lessons that we've learned and translate that into improving and augmenting clinical capacity in a resource-restricted center? Well, these are some examples about how we've managed to do that, because it was a priority at the start of the project. So in terms of imaging, we know that access to imaging is difficult. We've been able to integrate all research cardiac MRI studies that have been done into clinical care, where they get clinical reporting, and the findings get shared with the clinical teams. We also provide routine echocardiography as part of the research for follow-up, which is not necessarily available, and that we also translate back into the clinical care of patients. It's also important to remember some of the other initiatives that have happened. There's a big proposal and a move to do rapid sequence CMR, an initiative that's been started in Uganda, and we've also been involved with it here in Cape Town. And the idea is that you cut down the cost and the time required to do CMR, and therefore making it more accessible. We've also had opportunities where, because we have patients within a registry, we're able to select patients for device trials, and we've done a number of primary prevention device trials where we've been able to enroll patients because we don't have access to primary prevention devices within our service. And so that's been something that we've been able to provide care to a patient that is needed, but as part of a clinical trial and not at a cost. And we've also got a system in low and middle income countries where we recycle devices, which is, I think, a very important aspect of thinking creatively about how we can improve care. Family screening and genetic testing is very limited within our setting. We started a family screening service as part of the research program. And in the end, what we did was we screened as part of a research program and integrated patients that were diagnosed with hypertrophic cardiomyopathy into the clinical services. We've also provided genetic testing within our service here just in Cape Town. We've been able to do genetic testing on over 500 individuals. And that information is now being able to be integrated into the care of those patients. We set up a cardiomyopathy genetics counseling service that takes research results and integrates those into clinical care, and provides opportunities for predictive testing within the research program to family members that is not readily available. And then looking at drug therapies, there's often a care gap with access to drug therapies, but we've been able to collaborate with some industry to get some treatment options on a humanitarian basis for things like Fabry's disease. So I think that thinking outside of the box and trying to take a research service and augment the clinical care that patients get in our center, it has been really inspiring. And just to understand a little bit about how the genetics program has worked, so it gives you some idea. Patients programs that are recruited into IMITEP then get batch targeted next generation sequencing, and when they get a result, if it's negative, they get incorporated, if they have a strong family history, into discovery research from family members that are also recruited into the program. And if they're positive, they get referred into our integration program, which gives results, feedback, and counseling, and then expert review and feedback. And then we offer predictive testing to relatives. All of the cost of that is actually made by research and not as part of the clinical care. And so to an extent, it's reliant on ongoing funding from research, but it does mean that we're able to provide a care that our resources don't allow for. The last thing that we've been able to do through this pilot phase is promote education. Within our service, we've been able to enroll a number of students. We've had 13 people enroll into getting a degree, 5 PhDs, and a 6th one on its way. So we've really been able to grow the expertise in cardiogenetics and clinical phenotyping. We've also been able to support investigative meetings with invited speakers from all over the world, and do genetic counseling and pedigree analysis training, as well as inherited cardiomyopathy genetic variant interpretation. We held a workshop last year. So just in terms of wrapping up, stepping up research and care for HCM in low resource settings requires a number of steps. Firstly, improving our collection and understanding of what's really happening locally. This addresses the knowledge gap that is really needed, as well as the inequalities in research. Most research is related to research that's been done in higher income countries, and we don't really know how it relates to our patients. Integration of research and clinical resources is essential in low income settings. Collaboration and collective efforts are necessary between industry, between different organizations, researchers, and different institutions, and the clinical teams. And creativity is key. So I think thinking about creative ways and not relying on the idea that one day we'll have the resources, it's really important. Thank you very much.
Thank you so much, Sarah. I think that was a very interesting presentation, and it certainly also will launch some ideas and some discussion at the end. I remind the audience that you may ask questions. Just please scan the QR code, which you can see on the lower right part of the screen, and that way you can also interact. We're already receiving some questions, but feel free to ask any questions you'd like. We'll try to answer as many as possible. And now it's my privilege to introduce the next speaker, Lisa Salberg, that I had the chance to meet in Geneva during the World Heart Summit. She's the founder and the CEO of the Hypertrophic Cardiomyopathy Association based in the US. It was founded, this association, by Lisa in 1996 and has evolved into an international resource and support center for families affected by hypertrophic cardiomyopathy. The Hypertrophic Cardiomyopathy Association has an active membership over 15,000 families and also supports research, innovation, and policy initiatives to increase disease awareness, improve detection, and improve access to care. Liz has also published already 3 books, at least 3 books, I would say, and several peer-reviewed journal articles, and works to advance hypertrophic cardiomyopathy awareness and education. So we're very much looking forward to listen to you. Lisa, please go ahead. You are mute, Lisa.
You know, you think we've been at this long enough that I would have fixed that by now. My apologies. Again, thank you and good morning from New Jersey. I'm really delighted to be with you all today, and I've really enjoyed the first 2 presentations. So I'm going to tell you a little bit about the HCMA, a little bit about my personal journey, and how we're hoping to advance HCM awareness and management worldwide. Now, how do I advance this slide? I am not seeing the advance feature, I'm sorry. Could I get, there we go, thank you. So the organization was founded in 1996. I did so after the death of my sister in 1995, which was not the first death our family had encountered. I've lost multiple family members, including my grandfather, my uncle, my great aunt, my father, my sister, and I was diagnosed when I was 12 years old. So there was a mission in our heart, pun intended. So back then we started this thing called the World Wide Web page for hypertrophic cardiomyopathy, and how to teach people how to use the internet to engage in patient education and disease awareness. So we were really happy to be able to announce that this is our 28th year of service to the community, and our numbers have updated slightly. We have treated and worked with over 20,000 families worldwide. So it's pretty amazing to get this far. And we're happy to tell you all about our work and hopefully encourage some of you to get involved with us. Next slide, please. So I was asked to touch on my own personal experience. So I've created a timeline because it's way easier and you can take your time to read the screen. But the highlights are the diagnosis came as a result of the murmur being detected in the school physical. And I went pretty much asymptomatic and unmanaged for most of my childhood, only to land at 21 years old having endocarditis due to dental work, blood clot to the brain, and a stroke, and 5 implantable defibrillators over these many years. My ejection fraction dropped in about 2011. 2017, I received a heart transplant, and today I live very well with a donor heart from a lovely woman named Brandy that I I've never met her family. So I've been through a lot over these years, including the diagnosis of my daughter, niece, and nephew, and the management of those individual family members, as well as my 20,000 big-hearted friends from around the world that we've been able to work with through the HCMA. Next slide, please. How we break down our work is we believe that we have to teach people from wherever they are. So we have multiple resources available to engage with patients from literally all over the world. We have online discussion groups, which are open to everybody worldwide. We have a podcast that some of my fellow panelists here today have participated in episodes of Tales from the Heart. We speak to KOLs, we speak to patients, industry leaders on all things related to HCM. We are also faculty members on HCM Academy, which is professional education, and free CME courses to those in the medical field worldwide to help elevate the education of practitioners. Next slide, please. We provide individual peer support and navigation calls to every single person who contacts us. So having worked with 20,000 families, there's about 60,000 individuals that either have HCM or are being screened for HCM. So any one of those families can call our office at any time. If they are international, we have interpreter services, and we do Zoom calls so that it's a little easier to communicate. It's very tiring work. It's very laborious, but it is worth it because no two HCM families are identical, and they do need individual navigation. As Dr. Owens kindly referenced earlier, the HCMA's Center of Excellence program is in its about 25th year, and we have developed at this time 50 centers around the United States. We are working on international efforts, which I will speak of in a moment, and we provide online educational programming from our Center of Excellence partners monthly, and those are called the Big Hearted Warrior Tours. It was supposed to be an in-person tour with an 80s theme, but then COVID hit, and now it's just the name we stuck with. So you can find those on our YouTube channel at any time. Next slide, please. So I mentioned earlier that we're working on international efforts, and I'm really proud to say that we have partnered organizations around the world that are forming. We are working closely with our Australian partners and their board. The new board chair, Lee Bell, has been a long-time client of the HCMA, and we are helping move our information down to Australia and disseminate it there through her efforts. We've helped to create a nonprofit in Sweden, and that was launched last, I guess it was October of 22. Excuse me. And they are their own charity now, and we are, again, providing support in the development of the patient advocacy efforts. And we have recently begun work in Brazil. Really excited about the Brazilian outreach. So what does it mean to be an HCMA international partner? We try to identify a passionate patient who has the ability to donate time to help others. We find the clinicians, the researchers, the government agencies that we need to be working with. We have a staff member help them develop a strategic plan and help to develop and elevate HCM education in countries worldwide. We're slowly onboarding different countries. There will be a Center of Excellence type component based on the healthcare delivery system of that country. So each one will be customized. And we are looking forward to working with many more people. If you are interested in joining our international efforts, please contact me and I will put you in touch with our HCMAI representative. Her name is Michelle. Next slide, please. So in the United States, we're working on a state-by-state initiative. This initiative could be mirrored in any country. And this is some basic heart health history questions and ensuring that communities are heart safe. So the report card you can view on our website may not be applicable to your country, but you can certainly gain an idea of what states in the United States are doing and at what level. So we're looking for HCM Awareness Day proclamations or laws. We're looking for AED placement laws, CPR training for students, Good Samaritan coverage for those providing life-saving care in an emergency. Those are the preparedness elements. The HCM Act stands for the Healthy Cardiac Monitoring Act, and we are not only seeking to do screenings on student athletes, but all children in their well child examinations from ages 1 to 19. which aligns perfectly with the American Academy of Pediatrics statement issued in 21 on the same matter. We came to the same conclusions working independently that this was the most systematic and affordable way to identify children and families with genetic heart disease. And then we have some payment access issues, which hopefully the rest of the world doesn't have to worry about right now. Next slide, please. So this does not happen because Lisa sits at a desk. This is a team effort. And over the past 28, almost 29 years now, we've been able to build an amazing board of directors, staff members, volunteers, and partner organizations. And we thank our sponsors for making a lot of this work possible. And of course, I thank Brandy, my donor, for her. Without her, I wouldn't be here today. Thank you very much for the time to speak with you this morning.
Well, thank you so much, Lisa. It's very inspiring. Actually, I was very inspired by your presentation also at the World Summit in Geneva, and it's really fantastic. And I'm sure there's going to be a little bit of time to elaborate a little bit more. So now it's time to start our discussion among the three different faculty. And it's also the time for you to continue to ask your questions. Again, you can use the QR code. You can scan the QR code and send your questions to us. Well, let's start. And my first question comes to Anjali. You showed very nicely about the importance of early diagnosis, early access. And here one of the questions is, because we have two faces of this coin. On one hand, we want to improve the education for the non-specialists, so trying to identify, even at the primary care physicians and so on, these individuals. But also we want to increase, as you really nicely showed, the importance of having access to specialized centers for the let's say, the most sophisticated approach and the management of these patients. So how can we manage this, and how can we improve, of course, on one hand, the early diagnosis, and how can we focus on these two different areas, which they may apparently seem a little bit different. They are different, of course, but how can we work on both phases to improve the main goal here, which is early diagnosis, early identification of the individuals who have hypertrophic cardiomyopathy?
Yeah, it's a wonderful question, and one that we struggle with, that balance. And I think the way that we've been able to accomplish that here, at least make some headway, is by having a robust shared care model. So here in the northeastern section of the United States, we have a density of cardiologists that's pretty high. So there are very, well specialized places that have access to advanced imaging. So we partner with our local teams who have robust offices with access to imaging. And we say, really think about hypertrophic cardiomyopathy for your patients, get them to do the initial testing and establish a relationship. And over time, then those local cardiologists begin to know who needs to be sent to our center and when. And we do a lot of shared care, meaning they can get local testing done. If they get into a problem and they're in rapid AFib, the local cardiology team can manage that. But if there's a question of whether or not they need a defibrillator, they need a septal myectomy, they're pregnant, or they need advanced care, transplant, et cetera, then they know that they need to send those patients to us early. And we see them every few years as needed so that we can help to guide that path. So I think here in the US, we can do that and have a robust shared care model. We can also do teleconferencing. And, as we implement newer therapies, we're really thinking about how do we do the echo monitoring, for example, that comes along with prescribing a cardiac myosin inhibitor? And can we come up with more robust ways to share that care and management? And I think that, telemedicine, for what it's worth, may help us with that, and being able to access images, remotely, and be able to weigh in on decisions even when you're not in the office with that patient.
Very good, excellent. Sarah, you showed us very nicely the challenges that you face particularly in low and middle income countries, and you mentioned here the importance of data, the importance of education, collaboration, also integration. I would ask you, in your view and with your experience and with this registry that you now have, what have been the most important challenges that you faced in your own setting? Again, and you've mentioned different aspects, but what, in your view, were the most relevant hurdles, if you will, barriers, challenges that you face in your setting, particularly the countries that you know better, the one you work in, and the other ones that you have also some relation with?
So I think the difficulty and the challenge is that we don't have access to imaging. We don't have, we have very low proportion of cardiologists. And I work, in the center I work is the only center in Southern Africa that transplants in the state service. There are a few private institutions in South Africa, but it's very limited access. One of the big challenges is expertise. We ran a number of workshops talking about to try get people to take a family history and do a pedigree. But even with that, we have gotten very little information about families. And it's really just capacity. The difficulty, one of the biggest difficulties is that we don't have access to genetic testing on the continent. And I think that that's the same for many low middle income countries. If you can afford to pay for testing, you can have testing done where you get results. But then the other concern is that there's very limited expertise. There's no training in ICC and the cardiology training service here. And it makes interpretation then of the results and how you manage those patients going forward quite challenging. The good thing is that there are many enthusiastic people, and one of the most encouraging things about Imhotep is how it's translated into clinical care, not just 5-10 years down the line once the opportunity to look at the research has come up, but actually at the time of recruitment, the training that's happened throughout the study, the growing of expertise, the collaboration between sites. I get a lot of phone calls. Patients do get better care because they're part of the study. So I think that the registry basis is really important. It is challenging because we don't have the resources to diagnose the condition firstly, and then to make genetic diagnoses. And I think, we're never going to be able to reduce the inequalities in access to care or access to gene therapy trials if we don't have genetic testing, because that's a requirement to be entered into that. I think the one thing that we in lower middle income countries really struggle with is the imposition of first world or high resource centers applying those guidelines into our centers. And we actually need to be creative about how we do that. And there's this wonderful opportunity where you go, because we don't have all the resources, every test we do has to be thought about. Every test we do has to have a clinical question with a clinically relevant answer. So I think there's opportunity and there's challenge. The biggest for us is expertise, I think. And the more people that have expertise, because if you don't look for something, you're not going to find it. And access to genetic testing.
Yeah, that's great. I have a question from the audience for Lisa, and that is diagnosis of a serious disease like hypertrophic cardiomyopathy can be difficult to accept. How do you address supporting the mental health of those living with hypertrophic cardiomyopathy?
That is an excellent question, and I'm happy to say we think of the person coming to us as a whole entity, not just the heart. So we are looking at, is this person getting the care they need for their heart? How are they coping with it? And we help them walk through some of the processes of acceptance and understanding of their disease through many different resources. We have an app-based system that follows up with them and provides them with resources, support messages, access to discussion groups, recommendations in some regions to individual therapists who we may have relationships with. And we're going to be growing out that network of tying in the mental health professional. We do ask every one of our Center of Excellence programs to have a mental health arm of their program, to have identified the resources within their center to refer patients to, in hopes that we can elevate the cardiac mental health connection. We know patients who are more accepting of their disease, who have a better understanding, tend to have better mental health and tend to handle the stress of adversity a little bit better. So we see this every day, we work with it every day, and we are continuing to create new tools and ways of reaching people where they are, including current evaluation of a peer-to-peer system that could match individuals based on their country of origin, their national language, or chosen language. We're working on that too. It is a really important part of living with HCM, is to have that understanding that we're living with a little bit more anxiety than most people might. When your child has a disease and you have a disease and you're waiting for the shoe to drop somewhere at some point, it's probably going to be a minor thing, but you're still going to respond as if it's a catastrophe. So teaching people how to prepare for those events, what to think through, what emergency plans they need in place to give them some security, has a big impact on their mental health.
Great. And that brings me to the next question, talking about anxiety, to Anjali. And that is related with the question also from the audience about sudden cardiac death, because as we know, is probably the number one thing we want to avoid and to prevent. So the question is, sudden cardiac death is a big issue even before the patient knows about hypertrophic cardiomyopathy. So can you help us to understand how can we identify those individuals? It's a bit technical, but you may do it in a simple way.
Sure. And I'm not going to get into the global debate between the American guidelines and the European guidelines. Far be it from me to do that. But suffice it to say that there are a number of risk factors that we look at in each patient once they have a diagnosis of hypertrophic cardiomyopathy. And that ranges from how thick their heart is, what it looks like, whether it has scar tissue present, whether or not there are abnormal rhythms that are going on that we pick up via a Holter monitor. We take into account the size of their left atrium. We take into account whether or not there's obstruction to the flow of blood. And we look at the family history as well. And it's important to look at multiple generations to see, are there people who have died suddenly? And so we either take a one-factor, risk stratification system, which is typically what we do here in the United States, and say you have one very high-risk feature that may be enough to offer you something like a prophylactic defibrillator, or we use a scoring system, which is used more commonly in Europe, and here at our center we use both. And we really try to personalize that risk discussion. And I can't stress enough how it's a very personal decision. And so as healthcare professionals, our job is to take a look at that risk profile, explain it to our patients, and then help them to decide. But it ultimately is a very personal decision. And there are a number of different risk tolerances that we see in patients, and that's very important in the decision making. We know, as you mentioned, that patients can be completely asymptomatic and present with sudden death. And that is, of course, the most feared complication. Fortunately, it is rare, but still very feared. And so really looking at that family history, encouraging people to get screened so that we know if they have the condition early, helps us to prevent these poor outcomes. And that's typically how we address it.
Very good. There's now a question to Sarah, and the question is, what is the distribution of hypertrophic cardiomyopathy among your patients by race?
So it occurs in all race groups. We have increased numbers of patients within the mixed race and white populations, so European descent. Our mixed race population in South Africa particularly is very diverse because it comes from a combination of European, we have Malay descent, we have Black African mixed, we have, and that's more Bantu, which is very different from the North American sort of tribes. So our patient population is quite different, but it occurs in all race groups. So there's no distinction, and at the moment our numbers are too small to really have any race distinctions between them. It seems to be the same disease in all races. We have higher rates of hypertension within our patients of Black African descent and a much younger age of onset, and that's probably going to be a big contributor to this non-familial component with a polygenic risk. But we generally see the same disease across races.
Very good. Lisa, I'm sure there are a lot of patients that would like to have more involvement in organizations such as yours, and I see, and it's a very, very important gesture that an activity that you are doing, expanding to other countries and making it more international. But the question always comes up, if I'm a patient with this problem, how can I be more involved? How can I get more information? And you've shown already a lot, but I'm sure that after this presentation, more people may be willing to join or may be willing to help. So how can we improve also the access from people around the globe to your organization or other organizations that may help them to serve also in a way to contribute to what we are trying to do here, which is increase the awareness and improve the lives of people living with hypertrophic cardiomyopathy. Give us your advice.
Oh, Anjali, he asked for my advice. How much time do we have now? I'm not exactly sure. You figured that one out. So I would start by saying, if you are a physician and you are with a particular patient who seems that they want to do more, they seem very engaged in, maybe they're outraged that they are diagnosed so late in life, or maybe they're concerned that there's others out there. There's people who have that spark, and you all know some of them. That's when you say, are you interested in doing something for the bigger cause? And you can connect them right to the HCMA. We can talk to them via text message, email, Zoom call, whatever is easiest for them wherever they happen to live. We have talked to people in rural areas of India, and we're trying to work on initiatives there. We have talked to people in multiple countries in Africa, and we are trying our very best to find that patient with the spark, connect them with a physician who also has that spark, and look and assess the country, the situation. What is the most urgent need for people in that part of the world? We can help do an assessment. We've done this before. We're getting pretty good at it. It's still a learning process, but we need to have the stakeholders all come together. And it starts with a conversation. Do you want to get involved? Do you want to do more? And it can be a small gesture by distributing posters in your community to raise awareness in a physician's office about HCM. It can be that easy. Or it can be an evaluation of government policy. So depending upon where you're coming in from, don't be afraid to say, I'd like to know more. We can find a little project, or we can find a big project. It depends on the bandwidth, the funding, our partnerships in that country, but we can always do something to make the world a little bit better and a little bit easier for those with HCM and other forms of genetic heart muscle disorder. So
that's great. We only have a few more minutes, time runs, but just the final question to each one of you, in 1 minute, if you could just summarize a message that you would like to leave to the audience. We have it's a variety of different people listening to us, but from your own perspective, in 1 minute or less than 1 minute, one message that you would like to leave here at this time of that we live in, and how, in your own perspective, you can touch, on one hand, people's lives with this disease, and how can we do better to improve what we are doing for all these people around the globe. So, Anjali, you first.
Okay, I'll go first. So the first for healthcare professionals is keep hypertrophic cardiomyopathy on your differential diagnosis. You have to think about it to diagnose it. And once we do that, we have increasingly better therapies, targeted therapies that may one day change the trajectory of this disease. And so it's very important that we make that diagnosis early so that we can get them to the right treatment.
Very good. Sarah.
I think my main message would be to people who are working in low middle income settings, just because you don't have the resources doesn't mean you can't provide good care. And I was very encouraged by what Lisa said, because one of the most rewarding parts of the work that we've done is providing people and families with counseling and a place to go where they can ask when they have questions, where they can have their anxiety addressed, where they can have the confidence that their family is going to be looked at. So even in low income settings, I think the key is looking at the resources that you have in research and looking at the resources that you have in clinical medicine, and then trying to combine those to benefit both sides. So we need research, we also need clinical care. And so thinking about creative ways to integrate those two, it is possible.
Very good. Lisa.
1 minute message. Hypertrophic cardiomyopathy is compatible with a long and relatively normal life for patients. That should be the message you lead with as a physician, and you should align them with resources so that they can be supported, they can get the highest level care possible for them, and don't limit yourself by your borders of your country. There are resources, there are programs where we can help find transportation, find virtual consults, and I do dream of a world. I'm going to dream here for a minute, and if I put it out into the universe, it's going to happen. That is for a virtual worldwide clinic of experts to consult on complicated cases without fear of borders or in complete alignment with state and government regulations, but a safe place where physicians can go to meet with other physicians to help the patients wherever they are in the globe. That's just my dream.
Well, that's a fantastic dream, and I think it's great actually to close our webinar. I just want to say that it was very gratifying to have this discussion here with the three of you. I really want to thank you. I want to thank, of course, all the audience that was with us, our sponsor, BMS, and just to finalize to say that the hypertrophic cardiomyopathy was looked at here and exposed here by the different members of this panel. It's a condition that, although it's a serious condition, but it's a condition that we can do a lot about it, and that it's very important to early identify it, to increase the awareness about what it is, and also to demystify in a way the weight that it still has and the burden that it still has in many people. And our organizations, from health professionals to organizations such as the one that Lisa leads, that can actually help a lot of people to live through their lives, normal lives. You can have a normal life. You can have a normal family, as you just saw from the example of Lisa, which is a fantastic, quite inspiring story. So keep in mind that having hypertrophic cardiomyopathy is something that you can deal with, you can live with, and you can have a perfect normal life. But we have to improve. We have to improve all around the globe. And I like this idea, this dream of Lisa, of having sort of a global clinic, the virtual clinic that can help everybody. And in the future world, if we could have that everybody could be looked at and everybody could have access to the best possible care, that will certainly be something that we as health professionals, we as human beings, really would like that everybody will have that sort of access and that sort of capability to deal with their condition in an appropriate way. Well, I will close here this webinar. Again, thanking you for all the presentations, thanking you for your presence here, and continue to support also the World Heart Federation. It's a global organization. It's the only global organization in healthcare related with cardiovascular conditions. It's a federation of scientific societies, foundations, and patient organizations that is promoting cardiovascular health for everyone. So we are a global organization. Maybe we can see the seed for the virtual clinic in the world for cardiovascular health. That's also a big dream from all of us. I wish you all the best, regardless of where you live or where you practice, and let's continue to work to improve cardiovascular health.